Hello everyone, welcome back again. Oh, hi Sarah. So I'm sorry, we have to come back to Zoom again. So there was some
We
problem.
know soon. That's okay.
So did you contact Ruth? I've sent a mail to her.
Yes, she should be logging on. Oh, there she is. I see her.
Yeah. So yeah, sorry about the. I
No
apologize for
problem.
that again. So yeah, I think we'll be good to go in a few minutes. I
And I
think.
think what you can do, Beck, you can keep the host preferences, but you can just allow attendees to screen share.
Uh-huh.
Like if you go down to share screen or something, if
Yeah.
you allow attendee screen sharing, you can stay the host, but I can just share my screen, and then that way you can do all the letting people in and out kind of thing. Maybe.
Oh, yeah. Sometimes if by mistake someone clicks the screen, that's why we are not doing that. So.
Okay.
Yeah, but I
Okay.
can do that. I can do that. So can you try sharing the screen?
Yeah. Can you see?
Yeah.
Okay.
Let me see about mine. Oh. I'm gonna, Sarah, if you exit your screen share,
Yeah.
Okay.
I'll
think one will
check.
have to stop. Yeah.
Okay. You see it?
We're there.
Mm-hmm. Yes.
Great.
Yeah.
Awesome.
So
I'll go back and share my screen, Vivek. Is that,
yeah.
should I do that? Okay.
Yeah. So welcome everyone. After the technical glitch, good morning, good afternoon, good evening, wherever you are, and hope you're having a good day so far. So today we're going to have a webinar which will be divided into two sessions. So initially, Sarah will be hosting and she will be talking about most of the basic part of evaluation which are pertaining to COVID-19 patients. And Ruth, who has an experience of working with COVID patients, she will be sharing her experience on how they are tackling and what we should be doing. So it's going to be an interesting one. I'm really, really excited about this session. So over to you, Sarah.
Great. Well, thank you, SHAN, for having me again. I'm always honored to be here. We'll start right in. I have the boring part of the presentation. I'm going to go through all of the technical things, and then Ruth will get to tell you the real life examples at the end. Because since I've been working here, we have not seen COVID patients directly in our hospital. We are doing some isolation things, but we've not been working with COVID patients directly. Thank you all for filling out the survey as well. It was really good for me. It made me feel old because most of the people practicing are under 30. And it was good that some people have some intensive care experience, some people don't. We're going to start with basics and we're going to go a little bit deeper. So yeah, I would just go ahead and get started. Lots of different people compiled lots of resources for me. This is not all just from my research. Lots of people helped with that. So let's keep going. So we've got lots of different course aims and objectives. The WHO has said that this course can kind of be a good training that they presented to the Ministry of Health in Nepal, that we are having this training as well. So yeah, hopefully it's a good thing. So we're going to start out with some oxygenation methods. We're going to talk about intubation and how it can affect swallowing, talk about post-extubation clinical bedside, and then just look at a few of the different speech and hearing associations from around the world and how they're suggesting that their members protect themselves. And then just a very brief part on communication board training, communication strategies, and ways to train other healthcare workers and providers to help people with to help persons with disabilities who may be in isolation settings. All right, we're going to start with the basics. So when we're doing oxygenation, FiO2 is a term you will hear me saying over and over. I've got the definition here. The FiO2 is the percentage of oxygen a person inhales. So room air, what I'm assuming all of us are breathing right now, is about 21% oxygen, the fraction of inspired oxygen. As we know, the air around us is made of lots of different what is it, hydrogen, I don't know, carbon dioxide, all those different things. So anytime we give oxygen to a patient, if we put a nasal cannula on, if we put a mask on, if we do a bagging, we're changing the FiO2 to help them improve their SpO2. So what's SpO2? That's the oxygen saturation level. So that's the measure of the amount of oxygen carrying hemoglobin in the blood that is relative to the amount of hemoglobin not carrying oxygen. One of the main things our blood does as it goes through our body is takes oxygen to all the cells so the cells don't die. We all know that that's what, you know, an ischemic stroke happens because the blood can't get through, so the brain tissue doesn't get the oxygen it needs. So SpO2 is what's measured with our pulse oximeters. So I'm checking someone's SpO2 to determine if they need supplemental oxygen, if they need something, some change in the FiO2. So a normal SpO2, you know, if I were to use a pulse oximeter in my finger now and check it, I would be somewhere between 90 and 100. That's considered very normal. Patients with chronic lung disease, like COPD, usually have a chronic hypoxia. Their body's not used to having as much oxygen. So their oxygen SpO2 level usually goes down. At higher altitudes, our SpO2 goes down as well. So lots of times trekking guides will take a pulse oximeter and they'll measure how much it is when you're up somewhere at high altitude. In most cases, in most settings, if SpO2 is below 90% for a sustained amount of time, the patient's monitored, the doctors and the nurses are going to talk about putting some supplemental oxygen on. So this is the important point. The FiO2 will be changed to improve the SpO2. So here's just pictures of pulse oximeters. These are the devices you can put on fingers to check what it is. You can see, oh, sorry. You can see in the first picture, it says SpO2 is 97, and then it has the pulse rate, which is 64 beside it. The 97 is the one that we're more concerned about in that top picture. And then the next thing I wanted to show you, those of you with ICU experience, you're used to seeing these monitors quite a lot. If you've not been in an ICU setting, this may be a little bit confusing to you, but all of these numbers mean something, obviously. First number, the top one, and most monitors, is the heart rate. A normal heart rate for adults is between 60 to 100 beats per minute. If it's too slow, you know, that's bradycardia. If it's too fast, that's tachycardia. And those are things that doctors are looking at. We're also going to look at the amount of effort sometimes. If the heart rate's too fast, it shows us that people could be working quite a bit to swallow. The middle number, the one in blue, is the SpO2. Again, normal, that's the one we've been talking about, is 90 to 100%. The third number in yellow on this monitor is usually the respiratory rate. Normal adult range is about 12 to 20 breaths per minute. So you can see on this monitor there are about 23. The bottom numbers in white are the most recent blood pressure readings. Some monitors have this, some monitors don't. That's usually one, I see it about half of the time, but the top three numbers are always there if we're monitoring a patient in an ICU setting. All right, sorry, let me figure. So if we are thinking about someone's oxygen needs, and we're thinking about how much FiO2 do they need to increase their SpO2 because they're having trouble breathing, they have COVID, they have COPD, they have trauma, and they're having respiratory failure. This little grid here shows you from the acuity. The FLNC is low flow nasal cannula. Then you go to some of the mask and other things in the middle in yellow. And then the high flow nasal cannula, which is also a nasal CPAP, BiPAP, and mechanical ventilation or intubation are kind of where it's the most acute patients that we'll see. So we're going to go through what all of these different things are now. But first, different ways of getting oxygen give you a different amount, a different FiO2 of oxygen because of the method of delivery. So if you think about it, if I'm wearing nasal cannula, so I've just got my nasal cannula in my nares, I'm probably losing some of the oxygen from it. They're not tight fitting, it's kind of coming out. Maybe I have a stuffy nose, so maybe it's not all going in. If I have a non-rebreather mask on that's tight fitting around my mouth and my nose, then I may be getting the same liters of oxygen, but the FiO2 is different. The percentage of oxygen that goes into my body is different. A general rule of thumb, of course, there's nuance, of course, there's, clinical decision making, but generally, if we're thinking that the FiO2 required by a patient is more than 40%, oral feeding has a very high risk of aspiration because that's causing a lot of oxygen to be pumped into the respiratory system. I'll go over some of the reasons of why that affects swallowing in just a few slides. So some of the different oxygen modalities, and we're going from the least invasive, the least critical, the least acute, to the most acute. So the first one is low flow nasal cannula. You'll see me abbreviating this through the text. It's just NC, nasal cannula. This is what we see, I don't know, most of my days, this is what I'm seeing. So if you look at this grid here, the liters per minute, the LPM, is at the top, and then the percentage of FiO2 is at the bottom. Most of the monitors and most of the oxygen gauges that I've used here in Nepal, they have just the liters per minute of oxygen given. So they've got the gauge on it, and it's 1, 2, 3, 4, 5, 6. So it doesn't have an FiO2 on it. So knowing this chart is an important thing to know. Because we said room air, normal air is 21% oxygen. If we're just giving 1 liter of oxygen, we're just upping it to 24. We're not doing a ton, but we're giving them just that little bit of oxygen, right? And I should point out that this is all for adults. Infants and children have the FiO2 is much different. 1 liter of oxygen in a preterm baby is dramatically more FiO2 than in an adult. And then you can see how if I'm giving someone 6 liters of oxygen via nasal cannula, that's about 44% oxygen rate. Nasal cannula is considered one of the best ways to give someone oxygen when they're eating because it doesn't obscure the oral cavity, and the flow can't get much higher than about 44%. 40% is about the cutoff we like. So if I see someone on 5 liters of oxygen, I feel okay about them eating. 6 liters, I start to think, why do they need that much oxygen? The next method of oxygenation is a Venturi mask. I have not seen these in Nepal, but I, of course, have not worked in Kathmandu, and I have not worked at all the hospitals here. So I wanted to put in every means because I wanted you all to be familiar with it. And also to learn the percentages of FiO2, if you just do a Google FiO2 percentages with Venturi mask, it brings up all of these charts. Most Venturi masks give 40 to 55% FiO2, so it's pretty high. And so most of the times if you see a patient that needs this type of mask with the tubing and then it has the valve on it, we would typically defer the swallowing evaluation because number one, they can't take the mask off to have a bite because every time they take the mask off, their SpO2 is going to go down. So you're going to put them at risk of respiratory failure. And then also they're just having so much pressure coming in from that high flow of oxygen. The next one is the non-rebreather mask. I do see these, and when I worked in Tencent, these were used quite frequently in our high dependency unit, our HDU unit. Usually it's a 15 liters per minute of oxygen, which is 60 to 100% FiO2. These are patients in acute respiratory distress who are 1 step away from being intubated generally. If they are having this much oxygen needs, oral feeding is not recommended. The other one is an oximeter, and it looks like a nasal cannula, but you can see it has this white puffy on it. Again, we did not use these in Tencent, and we don't use them here at Green Pastures, but you could be using them other places. And you can see the percentages here. One thing I want to point out, if you remember back, I'll scroll back to our nasal cannula. If you look at what the percentage of FiO2 is for, like, let's say 4 liters per minute. So 4 liters per minute is a 36% FiO2 with low flow nasal cannula because you're not tightly packed around the nares. And then if you go and look here, 4 liters here is 41% oxygen. So this is giving you a significantly higher percentage of oxygen for the liters it puts in because of it has this reservoir above the nares. And so if you see a patient wearing this type of nasal cannula called an oximeter, your liters per minute that you know from nasal cannula are not accurate. You'll need to really think about the FiO2. Vapotherm high flow nasal cannula are similar to a CPAP machine, but it just goes through the nares instead, so the person still is able to talk and interact. Oral feeding is only recommended if the FiO2 is less than 40% for this one also. This one puts a pretty continuous high pressure of oxygen in, which makes that period of respiratory pause or apnea difficult while swallowing. So how does swallowing and respiration interact? Tachypnea is rapid breathing. So if we're breathing too fast, more than that, about 20 breaths per minute, that's called tachypnea. So if we're breathing that quickly, we don't have time for our normal pattern of swallowing. Our normal pattern of swallowing is we take our breath in, we breathe out. As we breathe out, that's when the vocal cords close, the larynx elevates and goes forward, and the upper esophageal sphincter opens. That's all happens, and we stop breathing for that point. We swallow, we continue to breathe out to expire, and then we breathe back in again. When we breathe out, when we have that expiration after swallowing, think about what that would do. If I breathe in while I have any pharyngeal residue, any piriform residue, where's the penetration going to go? It's going to go through my vocal cords, and I'm going to aspirate it. If I have a bit of residue and the pressure of the continued expiration happens, I have a chance to kind of clear my vocal cords and prevent some of the aspiration, or to remove some of the aspiration that could have happened. So our normal pattern of swallowing is we swallow on expiration. People with COPD, people who are air hungry, who are breathing, this is our clavicular breathing. We're using accessory muscles for breathing. We're not using those good thoracic or abdominal breathing techniques. They often have a discoordination of their swallowing. So they're trying to swallow while they're still doing an inspiratory breath, or in mid-swallow, their body's so air hungry that they're opening back up the vocal cords and trying to swallow, which of course makes aspiration happen. Our normal swallow apnea period or respiratory pause, a lot of the newer research is saying respiratory pause because there's such a bad stigma and scaredness saying the word apnea. So some of the newer research that I was just reading this week says respiratory pause is now the preferred term. I'm going to put both in here so you guys can understand it, hopefully. But normally we have a period where we hold our breath, where we, as we're swallowing, it takes about 1 second for adults. If we're having trouble breathing, if a person's respiratory rate is very high, they're going to get very tired while they eat because their body's not able to maintain that breath holding, that respiratory pause as well. So if you have difficulty coordinating the closure of the airway, it can lead to aspiration. And it can also lead to decreased airway protection and clearance, because your body's going to always choose breathing over swallowing. So if your body's very air hungry, it's going to open back up to get the breath, regardless if there's food and liquid in the pharyngeal space or not. So your body's always choosing air over swallow. So that's how aspiration can continue to happen. So this is just kind of something for you guys to think about. So time to swallow is about 1 second. So if I go in to see a patient and their respiratory rate on the monitor says it's 60 breaths per minute, when would the patient have time for that apneic period or the respiratory pause required to swallow? They wouldn't, right? Their body's trying to breathe so much. So if their respiratory rate is so high, and this is even the case if their respiratory rate is in the 40s or the 50s, if they're breathing like that, hyperventilating because their body's trying so hard to maintain its SpO2, then they have a much higher likelihood of swallowing an inspiration instead of expiration, which can increase the aspiration risk. If we think about the next question, how does this poor coordination increase aspiration risk? I kind of have already given you the answer. You're going to suck anything that could be in the valvular piriform pharyngeal space. If you breathe in immediately after, you're going to suck that down into the airway. You have less of a risk of, or you have more risk of just kind of everything falling back as well. And then also, most people say that they also swallow more air that way. And so they kind of get full feeling before they really are full because they're swallowing air instead of swallowing the food. So when do we do a swallow evaluation if we're looking at patients with respiratory failure? The reason I'm really focusing on all of these different respiratory things, and these techniques, this is not just COVID-19 patients, this is general ICU respiratory cases. We will talk a little bit more at the end about specifics with COVID-19 patients, but most of the things that we would do are related to the respiratory failure in COVID-19 patients, which is just still our general respiratory failure techniques. So when we do a swallow evaluation, we want them to be stable. We don't want them to have signs of respiratory distress because, like we've been saying, body's going to choose breathing over swallowing. So there's a protocol called the TIPS protocol, and the signs of respiratory distress are if they have a respiratory rate over 35, that's pretty sustained. Oxygen saturation is less than 90. They're using the accessory muscles to breathe, you know, the clavicular breathing. And then their heart rate is either too low or too high, or when they start to do anything that heart rate shoots up as well. So lots of times SLPs who are new aren't familiar with looking at the vitals, and they think, oh, that's just for the doctors and the nurses to look at. But if you think about it, these things are actually very important to us in our clinical decision making. If I can walk into a room, I can look at a patient sitting there, I can say, okay, they were extubated 24 hours ago. He's needing 40% FiO2 via an oximeter. His respiratory rate, even at 40%, is 40, and he's doing clavicular breathing. I already know that this patient is very close to the edge of reintubation. This patient is not in a stable respiratory position. So in that case, what I might decide to do is write my note, go in and talk to the patient, spend some time with them, and tell them why giving them anything to eat orally right now is not a safe option. You know, kind of getting that into place, that because of the respiratory status, they're at too high of an aspiration risk for me to do a bedside swallowing evaluation. So we're going to pause that, kind of when to do the swallow evaluation, and we're going to just look quickly at intubation. Intubation is being used in COVID-19 patients. There's varying research if it's beneficial for COVID-19 patients because of the lung conditions or if it's not beneficial, but it is still being used quite frequently. And so we're going to kind of focus a little bit on post-extubation dysphagia now. So intubation is when a flexible endotracheal tube is placed, and then below the level of the vocal cords, a balloon is inflated. And then that is used to create a closed system below the level of the vocal cords so that you can create pressure in the lungs. Lots of reasons for intubation. I'm going to kind of go through that. You guys are going to get this as an email to have all the slides. But let's think critically about how would intubation affect swallowing. So our normal swallowing requires strength, coordination, sensation, movement of the muscles. The way we keep a function is we use it. If I lay in bed for a week, what's going to happen to my legs the next time I decide to go for a run? My legs are going to be exhausted. I'm going to get atrophy. Same thing happens here with our laryngeal musculature. Because of intubation, the larynx cannot move to do a full swallow. So the muscles will atrophy very quickly. And when a patient's intubated, a system that's designed to be closed is open. There's a foreign body in the way, and the system's not being used in the way it would be. So here's a good visual of, this is, how our larynx normally is in adduction. Vocal cords are together. You can see everything. This is what, actually there's a gap here, but we should see, nice tight larynx when we swallow. The endotracheal tube goes right here in the middle, you can see from the second. So it's keeping the vocal cords pulled open in an unnatural position. They're trying to close. So as they're trying to close, as the patient's trying to talk, as the patient's trying to swallow, the edges of the vocal cords are being constantly bruised and beaten by that ET tube. If you have someone who's not an experienced anesthetist or doesn't have a laryngoscope to put in the tube, and they're doing it blind because it's an emergency situation, the patient needs to be intubated quickly or they're going to die, they're going to push that tube in, and they might miss at first. They may jab one of the vocal cords. They may hit the aryepiglottic fold and cause some contusion. They may put in a really big tube because the lungs are so compromised. So to keep the patient alive, you may have laryngeal trauma. And that's not saying anything bad against anyone. It's just something that we as speech therapists see. If you have people who are not as experienced, or if it's an emergency situation, you see laryngeal trauma much more. This graph is a great one. I would encourage you to go back and look at this on your own as well. It talks about quite a few things that could happen as an effect of endotracheal intubation on the glottic and laryngeal structures. You get atrophy, you get uncoordinated respiration, decreased glottic closure and the reflexes. It dampens sensation if the vocal cords are kept open for that long. When they do close again, you have less sensation in them. And then also you can have the laryngeal traumas because of the intubation itself. We often would see ulcerations and granuloma tissues on the vocal cords after a prolonged intubation or an emergent intubation. So please, this is a good chart to look at. Sadly, I just wanted to put this disclaimer in here. I don't have time to cover tracheostomy tubes and dysphagia in this lecture. I know some of you guys, I was glad to see some of you guys are doing this. Some of you guys are working with patients with tracheostomy tubes. This is a whole another wonderful part of our job, and it's great, but I would please encourage you, if you're seen a lot of patients with trach tubes, dysphagia, and you're thinking about what should I do, speaking valves, those types of things, how can I help with the decannulation process, give me a call, give me a text, send me an email if you're unsure about doing it, because I think we talked about this in a previous lecture. We want to make sure that we keep patients safe and that we give them the best practice that we can. The next thing I'm going to show you is gross pictures. One of the main things we can do while a patient is intubated or while a patient is NPO is we can be the advocates for oral care. Lately, we've been having quite a few stroke patients who've come to our hospital from other places. And I was trying to think about it, and Deepika can probably help me think about it. I can only think of one patient who's come in the past 3 or 4 months of the lockdown who's come to us without having oral thrush. Every other patient that's come to us over this past 3 months has oral thrush, and when we ask the family about oral care, they kind of say, no, the sisters do it one time a day, and then we say, no, you've got to do it multiple times. This is something you guys have got to help with. So there are lots of different signs of poor oral care. I think we can all agree that once you've seen poor oral care, you know what it looks like. And then some of the reasons it's so important to think about oral care is, they're dependent. And if I'm dependent because I'm sick and someone isn't taking care of my mouth, that has a lot of psychosocial effects. People come up to me and they say, oh, her breath is horrible, or what's this sore she has? it stops interaction, and interaction is already impaired when we're in the hospital. And then the middle one is the one that I want us to think about the most, prevention of hospital acquired infections. There was a study that I forgot to look up the actual results of, I'm sorry, but that said, I just remember it had a huge percentage of ventilator-acquired pneumonias and hospital-acquired pneumonias are correlated with poor oral care. So if we can keep a patient's mouth clean, when they aspirate, if they aspirate, they're not taking all of this colonized oral bacteria to their lungs. Microaspirations happen with NG tube feedings. Microaspirations happen following ventilators. Microaspirations happen with reflux. We hear often everybody aspirates. That is true, but if everybody aspirates and you haven't brushed your teeth in 2 weeks, that's much worse than if everybody aspirates and I brush my teeth every morning and every evening, because my mouth has got this huge bacterial load in it. So some of the oral care recommendations from one of the companies, which is called Sage, says you brush every 12 hours with toothpaste and anti-plaque. You clean with a swab and an oral rinse. So dipping a swab, or here at Green Pastures, we just use some, oh, sorry, I kind of couldn't switch to English. We use like a soft cotton, I'm so sorry guys, my brain only says narum rumal. We use like a soft cotton wipe, like a gauze pad, that would be what it is. I'm so sorry guys. We use a gauze pad and dip it in the mouthwash and just kind of teach the family to wipe out the mouth, and then applying some mouth moisturizer. So we ask families to help their family member clean the mouth 3 times a day, and then the nurses do it once per shift is the structure that we're trying to encourage here. So I know I'm kind of running through everything. We're going to go into a little bit about post-extubation dysphagia now. There's lots of research in this, lots of slides. This is to give you guys the backing up that you need so that you can feel comfortable to talk with doctors. If we're seeing COVID-19 patients, and just in our normal ICU study and work, post-extubation dysphagia is one of the things that I think is not often discussed. You just hear about patients getting a pneumonia after they're extubated, and it's probably because they were let to eat too early. So some of the best things to think about, these are the general guidelines. Patients should be extubated for 24 hours before anything is tried orally. Don't try anything. Give their larynx time to heal. Think about it. It's been open like this for as long as they've been intubated. It needs time to learn how to close again. The highest risk of saline aspiration is within the first 24 to 48 hours post-extubation. And these studies in 1998 and 2001 showed that 50% of patients intubated for longer than 48 hours aspirated in their first 24 to 48 hours post-extubation. Internationally, there's lots of different statistics on aspiration after extubation, but it's pretty high numbers, so it's something that we need to be aware of. 2 of the main risk factors for post-extubation dysphagia are the patient's age. So patients that are between, over 55 years have a 2.5-fold greater risk of post-extubation dysphagia, and the length of intubation also affects their post-extubation dysphagia. That makes sense to me. The older we are, the quicker our bodies atrophy in general. I could do stuff a lot easier when I was 20 than I can now. And then length of intubation, if you think about, if the longer the vocal cords are apart, the more atrophy that would happen, and the more sensation would be decreased, the more chance of trauma you would have. Silent aspiration is also huge. Some studies had 56%. One point I'm going to make is after intubation, the best practice is doing an objective swallow studies with a FEES or a modified barium swallow study, but generally are not being done in COVID-positive patients around the world because FEES is an aerosol generating procedure, and for modified bariums, you don't want to take the patient out of the room and expose other people to it. So we're relying on bedside clinical evaluations. And I know most of us who work here in Nepal do that anyway. And so we can use those techniques that we've worked on over our practice with our bedside clinical swallow evaluations in this case as well. You know, we're going to definitely do our good chart review. We're going to think about their oxygen modality, those types of things. How long were they intubated? Were they only intubated 2 days? Were they intubated 15 days? And then if they were intubated, part of your bedside clinical swallow evaluation should be a laryngeal voice screen. I've got this also, I've emailed it to BBEC, so you guys can print it out and use it. But it's got first a patient perception. How's your voice doing? Does it feel different? Does it feel the same? And then it has the clinical laryngeal examination as well. One of the main things we can do objectively at bedside for our post-extubation patients is the SZ ratio. And that's simply where, you guys know this, I think, you know, you say E, you say S, as long as you can. You say zzz, where you know your vocal cords would be together as long as you can, and then you divide it. The thing that's the most important is down here at the bottom. This is research-based and evidence-proven, so it's an objective measure. If the SZ ratio is greater than 1.4, then that's suggestive of a laryngeal dysfunction. We can't say exactly what it is, but we can say that there's a laryngeal dysfunction happening, and that's something concrete that we can look at and say, yes, I can prove this. We had a patient the other day whose SZ ratio was 2.6. We knew her voice was weird. We knew stuff was going on, but by seeing this, we could say, okay, this isn't just a respiratory control issue. This isn't a breath support issue. This shows us laryngeal dysfunction. So remembering that we have an increased silent aspiration risk after intubation, we want to proceed with caution. If you're going to recommend an NPO status because either the patient's current respiratory status or because of, you know, they were too soon post-extubation, they have laryngeal dysfunction, those types of things, start dysphagia exercises. This is what we can do. If I haven't been out of bed for a week, the first thing I need to do is move my legs, right? That's the same with our laryngeal musculature. This should be started as soon as the patient is able to. Get those muscles moving again, even if it isn't with swallowing. Doing our shakirs, doing our masakos, doing our effortful swallows, our bolus, you know, our tongue presses and swallows. This is just a usual rule of thumb or kind of tip for me. Usually as a patient's voice and respiratory status improves, we see an improvement in their swallow, which makes sense. Voice improves because the musculature is the same as what we need for the closure for swallowing. This slide I think is an important one maybe for you guys, and it may help. I think we're almost out of time. BBEC, I'm guessing you're probably going to give us another link, right?
Yeah, I think we can click the same link and come back again.
So the same link, okay. And Ruth, I'll need to finish up like 2 more slides before you do yours. I'm sorry.
So,
this little thing.
Yeah,
can we just?
You can finish this, or we can click. We can come back and discuss because you said this is an important one. So
yeah, why don't we click out then and click back in? Is that okay?
Yeah, so I'll request everyone to click the same link and we will continue from where we have left now. So we'll see you in a bit. Thank you very much.
Okay.
Okay, yeah. Welcome back, everyone. We'll just wait a little bit more so most of our participants can join now. So.
BBEC, am I still screen sharing, or should I need to do that, don't I? I need to start my video. Never mind.
Yeah.
Sorry. I think if you can allow screen for me.
Yeah, you're there. Can you try now?
Okay. Yeah, I'll try now. Okay, I think we're good.
Yeah.
Should I wait a few moments or should I?
Yeah, I think we can start. Or we are almost there. 90% of
Okay.
participants are in.
So I think about when I was first starting practice, and I have doctors who are pushing because they feel like, great, the patient's extubated, the patient's out of danger, I've done my job, I can pat myself on the back and we've saved this patient's life. And then I came in and I said, actually, I think they need an NG tube because they could aspirate. And the doctors are usually frustrated. And the doctors usually don't understand because they've told the family that once the endotracheal tube's out, that everything's going to be okay. And so you have two choices if you go in to see a patient and it's only been 12 hours since extubation, or you go to see a patient and they're extubated, but they're still on a non-rebreather mask and still needing 60% FiO2. Or you go to see them and they have no voice and they have significant laryngeal trauma signs and symptoms. And you know you're not going to want to give them even one sip of something to drink because they're at such a high aspiration risk. You can either tell the doctor you are going to defer the swallow evaluation because they're not appropriate, and you can go that way, or the way that I personally like to go is I start my clinical swallow evaluation. I go in and I see the patient, and I don't give them anything orally to eat or drink. And I spend my time teaching exercises, explaining about aspiration risk, and explaining about the respiratory system. That way, I've made a contact with the patient. I can tell the doctor I've met them. I'm not just scared to go in, especially if it was a COVID patient or if it's, you know, an ICU patient who's got a lot going on. I can show that I'm competent, and I can show that there is a medically valid reason besides just me not going in the room of why the patient should remain NPO. So I've given you a little example of what I would probably write instead of refusing to see a patient and saying patient's not appropriate for a swallow evaluation because of this, this, and this. This is probably a little note that I would write, and you guys can look at that and use it as you want to if you encounter doctors who want you to really get in there and see a patient. And then I think one of the most important things is to follow up with that patient to assess their readiness. Oftentimes a patient 12 hours post extubation, and then you see them again at 36 hours post extubation, you can see a dramatic improvement as their body recovers, and you can see such great things, and maybe they are able to eat at that 48-hour point, but they weren't at the 12-hour point. So following up is really important with these patients. So some of the exercises that we mentioned, and I think Ruth is going to talk about some of these as well. Starting exercises early, effortful swallow, Mendelssohn, the tongue pullback, Shakir, supraglottic, kind of a chin tuck against resistance, which is what I call a modified Shakir. And the Masako are all very indicated in this population to rebuild the laryngeal and pharyngeal strength. There's 2 podcasts at the bottom, and they actually have Facebook pages as well. So if you're looking kind of for current things, joining their Facebook groups is also great. I follow both of them and they're good. So if we're thinking about, so we've really done a really fast overview of respiratory care in our COVID-19 patients. But what about when the patient's intubated? And I think Ruth is going to go into some of this. I think she's had some of her patients, they were intubated 15, 20 days. I mean, long intubation periods. How are we going to communicate with them? How are we going to help the patients who maybe had a stroke while they had COVID? And so they're in isolation, but they're still a stroke patient with communication deficits. What about if they're a hearing impaired patient who gets COVID-19 and their family member that they normally sign with isn't able to be in the room with them because of the isolation? So what we can do and what we can emphasize, and something that we were able to do at Green Pastures, was teach some of the Gandaki province nursing staff some basic rehabilitation techniques. So even things such as making sure the head of bed is upright when the patient gets their PO, instead of letting them lie down. Emphasizing that good and frequent oral care. Using a mask with clear panels. Teaching doctors and nurses how to use a communication board with intubated patients. We're also going to email you. Oh, what did I do with them? Oh no, hang on. In my other presentation, I had the boards. What did I do? I must have saved it somewhere different. Let me get out of this and get it to you. Hang on just a second.
Yeah, we have the board, and we'll mail it to everyone as well.
Yeah, I thought I saved it on this presentation, but I must have emailed the wrong one out. Oh, and I'm using a different computer. Anyways, all right. Well, it's not gonna work because I'm on a different computer. Sorry, guys. I had Deepika may be happy. I had a picture of her wearing the mask with the clear panel as well in here, and she didn't give me necessarily permission to use it, but I did use it. Vivek, could you let me share screen one more time? I'm sorry, it's not letting me again. I clicked it, I think.
Yeah, you can do it now.
Okay, thanks. Sorry about that, guys. I switched computers. The last few things, I don't think it's really maybe the most important thing for us to look at, but I did include just from the UK, from the US, and from Australia, some of their precautions for SLPs. Most around the world are not doing aerosol generating procedures, so not doing as many feeds and nasendoscopy types of things, and are also, you know, wearing the government approved PPE to do things. And other things I wanted you guys to know about, WHO is doing updates. We can update each other through the SHAN group. And then this Facebook group called Med SLP COVID-19 Logistics is actually a pretty good crowdsourcing resource from people around the world that, you know, you can type questions on here, and then you can just kind of see what other people are seeing as well. So that's a group I joined, and I like to read some of the different things that people are doing and seeing. Here at Green Pastures, all my pictures I didn't put in, how sad. Here at Green Pastures, we are doing fees with patients who have an apparent need and who have been in our hospital for over 2 weeks as inpatients. So they're not COVID-19 patients, but they have had kind of an inpatient stay period. So with patients with strokes and those types of things, we are doing some. That's it from me. I know it was quite a fast presentation. I'm going to ask you guys really to be responsible enough to go back and reread it and then to email me questions as you need to. And I'm going to let Ruth take over. Ruth Chao is an SLP that I worked with in the US. She started working at the hospital that I left actually when I came to Nepal in 2016. And it's an acute care, all combined, it's about an 800 bed hospital that includes a pediatric hospital, a heart hospital, and it's the state of South Carolina's acute trauma center, and it's a stroke center of excellence in the state of South Carolina. So Ruth has had lots of acute care experience, and now it is one of the hospitals in South Carolina that is seeing lots of COVID patients. So I'm gonna thank you, Ruth, so much for joining us and giving us practical experiences. And I'm gonna turn it over to you now.
Awesome. Thanks so much, Sarah. That was a really informative webinar that you did with the oxygenation. So that was awesome. And let me go ahead and share my screen as well. So let's see if we can do this. How does that look to everyone?
Yeah, we can see.
Got it. Okay. So let me give you first an overview of what this portion of the presentation is going to look like. I want to first start out by talking about some of the predictors for aspiration pneumonia, as well as some of the risk factors for dysphagia that are really specific to the COVID-19 population. I'm going to briefly touch on PPE, since that is a big factor that goes into caring for these patients. And then I'm going to talk about 2 case studies for patients that I and my other colleagues in the hospital have seen. And I'm going to end on some dysphagia rehabilitation and also just some take-home messages. So as SLPs or anyone who does treatment with dysphagia, we are super, super concerned about aspiration pneumonia. That's our big thing. Oh gosh, I don't want my patient to start eating and drinking, and then they aspirate and they develop an infection as a result. So that is, of course, a very real concern that we have as dysphagia specialists. But something to keep in mind is that aspiration of food and liquids is not the only cause of pneumonia. There's actually multiple factors that go into play when we think about who's more at risk for getting pneumonia. So there's a study by Susan Langmore that looks at 4 main areas. And these are some areas that I'd want us to consider as we treat all of our patients, and especially our COVID-19 population. So the first area or big risk factor for developing an aspiration pneumonia is the patient's oral status. I know Sarah touched on this during her part of the presentation. If you have a patient who's coming in and they've already got poor oral care at baseline, so they have a lot of cavities, they're missing teeth, they have gum disease, and pair that with being in a facility, whether it's a hospital or a rehab facility where oral care is not as consistent and as frequent as we would like, you're going to be at increased risk of developing pneumonia from aspiration. So we know that it's the bacteria from your mouth that gets carried down into the lungs that kind of breeds that infection. So that's a huge risk factor to consider for our patients. The other factor to consider is also what is their functional status. There is research that shows that for patients who are dependent for feeding, who cannot feed themselves, they're at higher risk for getting aspiration pneumonia. When a nurse or a tech or even we are feeding patients, we can't control how quickly they go. I mean, we can, but is that really appropriate to this patient? We are controlling how much we give, but of course, the volume may not be the right amount, it may be too much. And so being unable to self-feed is definitely a risk factor. The third area for looking at developing aspiration pneumonia is, of course, swallowing and feeding. So this is where if someone is aspirating food and liquids, the chances are higher for getting pneumonia. But it's not limited to PO. It can also be from aspirating secretions, especially if you have really poor oral care. And like Sarah mentioned, you can still aspirate even with tube feeds. You can have microaspirations, you can aspirate the reflux. And also studies have shown that folks who are tube fed are way less likely to get good oral care. And so that increases the risk as well. And lastly, we need to consider what the patient's overall medical status is. What's the reason they're in the hospital? And also, what's the reason why they were maybe hospitalized in the past? Do they have a history of a stroke? Maybe they have some residual dysphagia that just never really got back to 100%. Do they have COPD that's now exacerbated because they're in the hospital? So they're going to have a really difficult time coordinating the swallowing and breathing because their respiratory status is compromised at baseline. Do they have congestive heart failure? So we know these patients are prone to getting fatigued quickly. And again, with the shortness of breath that can come with congestive heart failure and cardiac disease, especially in the acute stage of illness, that can compromise swallowing. And then people who have GI disease, such as esophageal dysmotility, are also more prone to developing aspiration pneumonia. So when we consider our patients, yes, we want to look at how is their swallowing. We also want to consider other factors like impaired health status or poor oral care. These are the 3 pillars of dysphagia, or not dysphagia, but these are the 3 pillars for putting people at higher risk for getting aspiration pneumonia. And so we want to consider all 3 things as we go into our evaluations. So that being said, our COVID-19 patients are unfortunately very susceptible to having multiple risk factors for dysphagia and also for developing an aspiration pneumonia. So like Sarah mentioned, a lot of people with COVID do require intubation. Not all. I have seen patients who aren't ever intubated. They just maybe require BiPAP or nasal cannula even. So it's not every COVID patient who needs intubation, but a lot do. And so when you're intubated, you have to consider what is the laryngeal trauma that results from that tube being in between the vocal cords. Is there going to be swelling, redness? Is that going to cause trauma because you have something that's jammed in there into the laryngeal vestibule? And then, of course, you have disuse atrophy. The longer they're intubated, the longer the muscles are just sitting there. So that's also a factor to consider for this population. Sarah mentioned, yes, some of these patients do eventually need to be trached. So that has a whole nother slew of issues because now you have a tracheostomy on top of a prolonged intubation. And so that does complicate the picture. And then Sarah did mention high oxygen requirements. So I'll kind of leave that. I think we had a lot that we just heard about that. And so also with COVID-19 patients, they tend to be pretty altered as far as mentation is concerned. So there's a lot of reasons for this. There's COVID-related encephalopathy. So just because of the nature of the disease, it does affect the brain. It can make you more confused. They can have ICU delirium, which I'll mention in a little bit. They can be altered because of medications that they're taking. A lot of these patients are sedated while they're intubated and even afterwards because they're delirious. So they ended up being sedated and then it's a cycle. There's a question of whether they could possibly have hypoxia because we know that coronavirus does attack the lungs. So is there a period where the brain isn't getting enough oxygenation and that leads to some sort of brain damage? And then you come in, but you still have your baseline issues. And so being acutely ill can exacerbate any baseline cognitive deficits. Some other risk factors for dysphagia include just general deconditioning. I will mention fatigue later on in this presentation. So we're finding that these patients are really weak. And of course, if your body is weak, that includes your swallowing function too. And then also any pre-existing health issues doesn't help their swallowing either. So let me go into some of the risk factors in a little bit more detail, especially factors that are specific to this population. So what we've seen in the States is that a lot of these patients are being proned when they're on the ventilator, and sometimes even if they don't need intubation, they are still prone. So basically proning means that instead of lying on their back, they're flipped and they're lying on their stomach. And this is for multiple hours at a time. The goal of proning is to help with the respiratory distress that we see in these patients. And you can have proning for patients who aren't COVID positive too. It's not exclusive to this population, but it's become a more popular standard of practice, at least in the States. So the goal is for you to increase oxygenation and increase lung function. So when you're lying on your back and you're in your bed, gravity is kind of working against you because it's pushing on your heart and your diaphragm to compress the lungs. So the lungs have to work harder to open up. When you're flipped on your back, the heart is facing down. And so the back and bottom of your lungs are able to expand, especially since you're not lying on them. So proning is good for helping someone's respiratory status, but it may not be good for swallowing. Now, why do I say that? It's because when you're flipping patients back and forth, there's a higher chance of accidental extubation. We know that it's traumatic. It's not, in a sterile environment. It's literally we're moving the patient and oops, the tube gets pulled out. So that is very traumatic to the larynx. Also, there is concerns for laryngeal trauma from proning. They're starting to have some research about this. It's still preliminary, but if you think about it, while you're moving your patient, you know, the tube could be going from left to right, up and down. It's not exactly the most stable thing. It's not locked into place. And so that excessive movement can certainly kind of damage your swallowing muscles. And also there's just concern too for pressure. So you're on your face, there's pressure in your mouth, there's pressure along the side of your face, and so there's concern for swelling resulting from that too. So typically in a hospital setting, the pruning team consists of the nurse, the respiratory therapist, the doctor, and in some hospitals, PT or OT, because they help with positioning. But I think that as SLPs, especially if you work in a hospital where you have a relationship with the doctors, you may be able to raise more awareness about how to safely prone. And because you're thinking about the larynx while everybody else is thinking about how are their oxygen saturations looking like, and how is this body moving from front to back. So you can think about, you know, is the neck like hyperextended? That's not really a normal position to be in for 10 hours. Is there a way to pad the tubing so that it's a little bit more stable instead of just going back and forth? So I think that we can advocate for our patients in that way. And also it gives us a little bit of a red flag too. So we know that when we go in to do our evaluations, if the patient has been prone for long periods of time, over multiple days or even weeks, that could be a potential source of dysphagia as well. Another risk factor to think about for all patients, but especially with our COVID patients, is delirium. So this information I pulled from a presentation from a psychiatrist who's a lot more well-versed in delirium than I am, but it was a really good resource to look into. So just to define delirium, it's a disturbance of consciousness with decreased intention. The way you think about delirium is it's almost like in this half awake, half asleep stage. So we all go through it. You know, you're just drifting off to sleep, but you're not quite there yet. And everything is kind of murky. You're in this almost dream state. That's what delirium is like. It is caused by a medical condition. It can wax and wane throughout the day. It does develop over a short period of time, so it's not to be confused with dementia, because we know dementia is a slow progression of cognitive decline. With delirium, it can happen over a shorter period of time. But it does have characteristics that are similar to depression and dementia. So it's hard to parse out what is what sometimes. But the thing to remember is that delirium can progress past the acute stage of illness. So we always say, oh, the patient has ICU delirium. Yes, that is a very big risk factor in the ICU. But the patient can be on a regular general floor, or they can even be in rehab, and delirium can still persist, which was something that I actually found pretty interesting to think about from this presentation. What are some of the symptoms of delirium? You can have patients who are hyper alert. So these are the ones who drive the nurses nuts. So they're pulling at IVs, they're yelling, they have to be restrained. These are super hyper alert patients. The other type of delirious patient who gets under recognized is the hypo alert patients. These are the ones who are generally quieter, they're more sleepy, they're kind of drifting in and out. And so that is also a sign of delirium. With delirium, you can also have some language changes. So it can be anything from a patient who just isn't really talking at all to a patient who's talking, but really what they're saying doesn't make any kind of sense. You can have cognitive changes. That includes higher level cognitive changes too, especially if the patient is out of the ICU, but still feeling the effects of the illness that landed them in the hospital in the first place. You can have disorientation. So patients tend to be oriented to themselves, but the disorientation comes into play when it comes to year and location. You'll see that more often. And then they can have hallucinations. This can be visual hallucinations. So these are the patients who say, oh, my sister's sitting over there. And really there's no one else in the room, or there's spiders crawling up my wall. That's a hallucination. They can also be misinterpreting visual or auditory stimuli. So you have a patient who hears someone outside talking and they say to you, oh, they're talking about me, I know they are. That's not really reality. So that could be a sign of delirium as well. You can have mood changes, more fear, more paranoia, and also abnormal sleep patterns where you're sleeping during the day and awake at night. So what can we do about delirium management? So the thing about COVID patients is that really nobody wants to go into the room unless they absolutely have to. And then once they get in the room, it's really do what I came here to do and let me get out of here as quickly as I can. And that's very understandable. But it is important to remember that sometimes these patients are alone in the room, the windows are closed, the blinds are closed, it's dark, the lights are off, and they're really just in there by themselves for long, long stretches of time. So when we go in, make sure you reorient the patient. It's like, hey, where are you right now? It's like, oh, I'm at the store and it's 1862. Reorient the patient, say, no, you're in the hospital, you're here for this reason, this is the year. And the tricky thing, another thing to think about is that the tricky thing is family members can't visit because they're COVID positive. So can we bring familiar things from home to let them become a little bit calmer? So the example that the psychiatrist gave in the presentation was bringing a pillow from home. Let's say the patient wakes up in the middle of the night. They don't know where they are. It's dark. It's an unfamiliar place, but they're on the pillow from home. So they can smell, it smells like home. The feel is familiar. And so that can help manage a delirium as well. Early mobilization is important. So getting the patient out of bed so they're not in the bed all day. And then really trying to maintain a day and a night schedule. So when we go into these rooms, making sure that the blinds are open, it's light, they can tell that it is daytime instead of just being in a dark, dark room all by themselves. Okay, so I'm gonna go into some of the case studies, but before I do that, I did wanna talk about PPE. In the hospital where I'm working now, there's a few types of PPE that we use. The N95 or the duckbill mask, it just depends on which one has a tighter seal. A face shield, gown, gloves, and sometimes I wear a surgical cap, but half the times they're not really available. So these are the four main things that I really do wear when I go into a COVID room. Some of the tips for wearing the PPE, at least as far as we were told in the hospital, is first of all, you want to try to face the patient. So when you walk in the room, you want to assume that the front of your PPE is the dirty side and the back of the PPE is clean. And the reason for that is because when you go to take off your PPE, you're reaching in the back to take it off. And so if you assume that's clean, that's a little bit more sanitary. And so when you're doing your evaluations, try to keep facing the patient. Have I ever accidentally turned my back and went off to get some towels and then realized as I'm halfway across the room, whoops, the patient's coughing and my back is exposed? Yes, it happens quite often. Do I think the nursing staff maintained the clean back, dirty front? No, absolutely not. So this is a general guideline to go by. It's something that's helpful, but if you don't do it, it's okay too. But keeping with along the lines of the back is clean, we usually, if we're tying our gown, we don't tie in the front, we tie it in the back. And so this is because when you're getting out of the room, you take off your gloves, you hand sanitize, and then as you're going to take off your gown, you're reaching in the back to untie it. So you want to kind of go in the back. If the tie is in the front, then that's dirty, and then you get your hands dirty as well. Dirty is kind of not a great word to use, but you could say possibly infected. So tie in the back. Also, we do a bow tie, not a double knot, because the tricky part about the gowns we use plastic ones. If they're double tied, you have to rip them off, and then that can be aerosol generating too. So do a bow tie so that you can just pull, and then you can just undo the tie instead of really yanking at it. What I have found really helpful when I'm in the COVID rooms is to have someone outside who can get something from me if I forget it. Chances are you go into a room, you're like, oh man, I forgot to bring this into the room. I forgot to bring that into the room, and you're already PPE'd up. And so it's kind of frustrating to have to take everything off, go outside, and then come back in, especially since we are trying to conserve PPE. And so in the hospital where I work, there's actually a site manager who manages a couple COVID rooms, and they kind of check people in, they make sure that you're wearing your PPE correctly. And if you need something, you can poke your head out and say, hey, can you get me that? And they can go around and get it for you. I understand that's not always possible. So sometimes, I just let the nurse know if there's no site manager, I let the nurse know, hey, I'm going in. Hopefully they're aware. And then if I start banging on the door, someone can come and help me get something. Another thing that has been helpful has been to hang up the protocol for taking off the PPE outside of the room, but through a window. So here we have a lot of steps that you have to do in order when you're taking off your PPE. So when you first start out, it's really difficult to remember, okay, what do I take off first? What do I take off second? And so for me, it was really great to have something that I could see through the window and go down the checklist. Okay, I did this, I did this, I did this, just to make sure that I'm remembering everything, especially since once you're in the room, you're kind of in a heightened state of anxiety anyway. And so it just helps to have a memory clue to remind you of what you need to do. When you do take off the gown, you want to make sure that you gently drop it in the trash. So don't ball it up, because that can be aerosol generating. So you just take it off and let it drop into the trash can. Remember to sanitize the door handle before you leave, because when I'm ready to get out, most of my PPE is off already. My hands have been sanitized, and you want to make sure you're pulling on a clean door as you go out. And then I don't know what the protocol will be for you all at the hospital where I'm working. I keep my N95 on until I leave the room. All of my other PPE is off, but I keep my N95 in the room. Once I exit, I then take it off. And when you do take it off, make sure you don't grab from the mask. You want to grab from the straps and kind of lift it over your head and then drop it into a trash can. You don't want to pull up because the front is contaminated. Some additional thoughts about working with COVID patients in general is that they're going to cough a lot. And I know this kind of seems like, oh, well, of course they do, they cough. But it is kind of crazy how much anxiety coughing can induce. So I think even now, just going out in the community, someone coughs and you're like, oh, whoa, back up. Don't spread your germs. The anxiety is even more heightened when you're in the room. So just be aware that's normal. You can expect it. And also anxiety is normal too. It's okay. You have your PPE on. It's there to protect you. If a patient coughs with or before, during, or after your swallowing evaluation, it's kind of the nature of the illness, and it's also the nature of our jobs because we make our patients cough all the time. So just as long as you put your PPE on correctly, you should be good to go. And then something that I've also found is that I found that I have been doing a lot more than I expected in the room, things that I wouldn't normally do. So usually I don't really help a patient use a urinal. If they say they need to go to the bathroom, I let the nurse or a tech know. When you're in the room though, and really no one is going in and out, sometimes you got to do something that's a little bit unexpected. So the patient says they've got to use the bathroom and they have the urinal right there. They can't use it themselves. You know that if you don't help them, nobody's going to, and they're just going to urinate in the bed. So sometimes unexpectedly, you have to do a little bit more than the norm. But also, that being said, sometimes you will be asked to do things that you shouldn't be doing as someone who's not a nurse. So I've had a nurse ask me before, hey, if you're going in the room, can you do this, this, this to the IV? That's out of my scope of practice. So sorry, would love to help, but you've got to be the one to manage the IV. Or I'm not comfortable ambulating patients. So if they need, a lot of assistance and they need to go to the bathroom, sometimes during those cases, you say, hey, let me get some trained help. But I think it's, walking that fine line between knowing when to go the extra mile versus when to say, no, I've got to cut it off here. But those are just some thoughts to keep in mind. So let's go into our case studies now. I'm going to start out with the first one. So you've got a 72-year-old male. He has a history of reflux. He was admitted on March 21st with fever, cough, and diarrhea. And he was diagnosed with COVID, pneumonia, sepsis. He was intubated for 16 days, and he has ongoing altered mental status through much of his hospitalization, especially when he's intubated, but also after. So when you first walk into the room, you just think, what are this patient's risk factors for aspiration? Okay. So keep that question in mind as we go through the next few days of SLP trying to work with him. We were consulted around the 13th. This is a few days after he got extubated, but he was just so confused that he wasn't really appropriate for any sort of speech evaluation. So the speech therapist tries to see him on the 14th. We can't. He's lethargic, he's confused, he's restrained, he's trying to bite his restraints. So we deferred. And the same goes for the 15th, the 16th, and the 20th. And I have this slide because it just highlights sometimes how long this altered mental status can persist. It could be delirium, it could be medications, it could be the COVID, it could be a number of different reasons. But for whatever reason, this patient is he was extubated on the 9th and now it's the 20th. So it's a week and a half after extubation, but he really isn't appropriate for speech to see at all. So just keep that in mind as you go in and do your evaluations. We finally were able to do our formal evaluation on the 21st. So at this point, it's 12 days after extubation. The patient is on room air. He doesn't need any oxygen, which is great. He is on just a general floor. He's not even in the ICU anymore at this point, and he does have an NG tube in. But he is pretty confused. So if you remember the Glasgow Coma Scale, the highest number is 15. 15 is you're opening your eyes spontaneously, you're following directions, and you're completely oriented. This guy's GCS was a 13. So he wasn't oriented, and he was just saying words that didn't make any kind of sense. We started out with the evaluation, and so the oral mech appeared within normal limits. But as you do the laryngeal exam, you find that he has moderate to severe dysphonia. His voice is breathy, it's soft, it's hoarse. He doesn't have a great pitch range and decreased volume, and he's got a really weak cough. He's so confused that I can't do the SC ratio. He's not sure.
Yeah, sorry. We're running out of time. So I'll request everyone to rejoin with the same link and we'll continue from there. Is that okay?
Okay, that's fine. Yep.
Everyone, thank you very much. Please rejoin us with the same link and we'll continue with the case discussion and we'll go on to question and answer. Thank you very much. Hello and welcome everyone. Thank you for bearing with multiple logins and logouts. We'll wait a little bit so that everyone can join, and we are still waiting for Ruth and she's here now. So I will just make her the host, and yes, Ruth, if you can share your screen.
Sure. Is everyone back?
Yep, we're still getting them back, so they're joining. So we'll wait a minute or two, and then we'll start over. We've got a question or two, which I will share with you in a moment, and we can discuss that after you finish your presentation.
Okay.
Yeah.
Ruth,
Yeah.
do you think maybe finishing this case study would be good, and then maybe take some questions? Would that be and then if we have time for another case study, would that be a good way to do it?
Sure.
Does that sound okay to you? Maybe after this case, some questions, if that works.
Yeah, totally.
Yeah, okay, then, yeah, we can do that. So we'll continue with the presentation. And if anyone has any question, you can type on the chat section and we can do the discussion and go back to the second case study. Yeah.
Let me see about sharing it.
Yeah, you.
All right. How's that look?
Yeah, that's good.
Great. Okay. So let's go back to the last part of this slide. The patient has moderate to severe dysphonia. I can't complete an SC ratio like what Sarah had talked about because he is so confused, but I'm guessing that he's got some sort of laryngeal dysfunction just based off of the way his voice sounds. So I do a swallow evaluation. He takes a little bit of ice, some thin liquids. He has some oral dysphagia, but no pharyngeal symptoms. However, while he's taking his PO, he is very inattentive. He's hyperverbal, he's talking with a straw in his mouth, he needs consistent cueing to even take a sip and swallow because he's just so altered, he's so distracted. So even though he didn't show any pharyngeal symptoms, no signs and symptoms of aspiration, I recommend NPO. He isn't ready at this point to initiate a diet. And he's so confused that he can't do any dysphagia exercises. Now, speech comes back a few days later. Now this is 15 days after extubation. He's still on room air, still with the NG tube. Now his GCS is 14. So he's not saying inappropriate words anymore, but he's still disoriented. We are finally at this point able to do an SC ratio. So the ratio of that is a 2 to 1, a 2. And remember, anything over 1.4 denotes that maybe there is some sort of dysfunction. So he is probably having some issues because he was intubated for such a long time. He still has moderate dysphonia. We try thin liquids, we try nectar thick liquids. He's coughing with both, and we recommend NPO. He is at this point able to start dysphagia exercises, so I do 10 effortful swallows with him and then educate and try back again in a few days. 18 days after extubation, still GCS is 14. This time, try thin liquids. He shows signs of aspiration with that, but with a cough, but he doesn't show any signs with the nectar thick liquids. I want to direct your attention to the quantity of nectar thick liquids that were trialed. We gave him a good portion, especially for folks who are intubated for such a long time. We know that silent aspiration is a risk. And sometimes when you try more volume, then they start to show more subtle signs of aspiration. Also with him, because he's so confused, I want to see how he does with more volume. Can he potentially get through a whole meal, or is he going to take maybe 60 mLs and then he gets distracted again and can't get through the rest? So he does relatively well with 240 milliliters. And so the recommendation is made for nectar thick liquids only. At this point, we don't try puree, and it's mainly because he's at high risk for aspiration. And so because we can't do any objective testing such as a FEES or a video, the idea is that we want to progress gradually. So we put him on nectar thick liquids, say, okay, let's see how he does on this. We'll come back and revisit in a few days. On top of that, he's still confused. So he can't do dysphagia exercises at this point. So he has that altered mental status, that prolonged intubation. Those are all the factors that we're thinking of as we decide what diet he's appropriate for. 20 days after extubation, this time his GCS is 15, so he's oriented, but still confused. So he's not exactly back to his baseline, his cognitive baseline. And this time, the speech therapist tries the thin liquids and purees. He shows signs of aspiration with both. We continue with the nectar thick liquids, and we attempt dysphagia exercises, again, with varying success because of his confusion. But we do start an expiratory muscle strength trainer, which, if we have time, I'll get to that towards the end. And it's a device where you can blow into it and it works on your cough, which is important for COVID patients because we know their lungs have really been affected by the disease. A couple days later, come back, try the purees again. He looks good, no signs of aspiration. So we put him on puree diet, nectar thick liquids. Don't try the thin liquids. We say, okay, let's see how he does with puree nectar. And then day 25, after extubation, he does great with chewables, with a regular diet, but is still coughing with thins. So at this point, he gets on a regular diet, nectar thick liquids, and we still try dysphagia exercises. Again, he's still confused, so we hold off on that. You're sensing a trend here, I think, for patients who may or may not be able to participate in exercises in the acute stage of illness. And then finally, this is what, geez, I can't do the math, 4 weeks after he's extubated, finally he looks great on thin liquids, regular diet, thin liquids, and he is discharged from the hospital, not because he was on the nectar thick liquids, but because everything else medically, he was stable enough to leave. So what are some of the take-home messages to draw from this case study? The first one is that dysphagia recovery is a long road, especially the more complex the patient is, the more prolonged their intubation is. It's going to take a minute for swallowing to come back in a lot of cases. The second is that altered mental status is a barrier to you even being able to start your evaluation, and definitely to you being able to initiate a diet. And the thing to remember is that AMS, altered mental status, can persist even after the patient is out of the ICU. The patient that I just talked about, he was out of the ICU the entire time that speech was working with him. But as you can tell, he was still not completely back to his cognitive baseline, which did affect his ability to work with us, do exercises, and get on a diet. One thing to remember is that when we consider the whole patient, we may recommend NPO, even though they're not showing signs of aspiration. So you want to take a look at the entire patient as a whole. No, they're not coughing. No, they're not throat clearing or having a vocal quality when you're giving them whatever it is that you're giving them. But does that really mean they're not aspirating? You have to look at every other factor that could be contributing to dysphagia and help that make your assessment. And then finally, on this slide, I think I have another slide after this. Before you initiate a diet, you want to try to push for volume. These patients tend to fatigue quickly, and also, again, the risk of silent aspiration is high. So try to push for volume, and then if they're still looking relatively good on it, initiate the diet then. One thing to keep in mind is really educating the staff about aspiration precautions. And so sitting upright, as far as the patient can go, going slow, taking small bites and sips, feeding only when awake and alert. It's really important to let the staff know about these precautions because we can't be in the room feeding the patient all the time. Half the time the patient is so confused that they don't think, oh, maybe I should raise the head of my bed, and perhaps they're impulsive, perhaps they're pocketing. There could be a slew of reasons why the patient can't manage precautions on their own. So really emphasizing that with the staff who are going to have more contact with these patients than we do. And then, of course, we want to try dysphagia exercises as much as we can, but in the early stages of acuity, that may not be the most appropriate. So how can we continue rehabilitation even after leaving the hospital? So where can outpatient or a rehab facility pick up where we have left off from the acute hospitalization? It's always a continuum of rehabilitation. So let's keep that in mind. And then I can take any questions that you guys have. And I'm going to stop the share.
Yeah.
And
Thank you very much for a beautiful presentation. And I must thank Sarah and Ruth for like taking from the basics to almost like taking care of the patients who are right out of the ICU. So it's definitely an eye-opening. So we have a few questions. So I'll straight ahead go into the questions and then we can discuss further more, I guess. So one of the thing is about the PPEs that you use. So do you use the PPE as like a per patient one, or like you use across the patients and then change it all together?
it depends on where you're going next after the PPE. So as a general rule, I take off everything before I leave the room. The only exception is if I'm going to a COVID room right afterwards, I'll keep my N95 on and then I'll just go straight to the next room. But the gown, the glove, I'm taking everything off because I mean, you're assuming that your PPE is infected, and so you don't want to be walking around the halls wearing it. And then sometimes I think if we have the N95 on, I'll go outside the room and I'll put a regular surgical mask on over the N95 and then go into another patient's room, take off the extra surgical mask and the original N95 on underneath.
Yeah, I think that's quite widely accepted as well. What we tend to do here in the UK is do per session if you are doing with like non-COVID patient, but if you are going towards the areas and if the procedure is aerosol generating procedures, we generally tend to change with every patient. So I think that's a common thing. So the next question follows on the same one. So if you're using N95 masks, like do you use it one at a time and then like throw it away, or like is there any way that you can reuse them, or how does it work? Yeah.
If you reuse them, they have to be cleaned. Our hospital has like an area where they do cleaning, sanitizing of the N95s. So when I take off my N95 and I'm not going directly to another patient's room, I store it in a paper bag. I give it to the site manager and they direct it to the cleaning site. That being said, if there's not a way for you to do that, ideally you shouldn't be saving the mask for another day because that is infected.
Yeah. So how many times can it be like reused? Do you have any idea on that? That was one of the questions.
Like after it's cleaned?
Yes.
That I'm not sure.
Okay. Yeah. Yeah. And there's one more question which was talking about like if the patient is in like ICU in prone position, I'm assuming the question is prone positioning, in the proning position. And is it possible to do oral care and other things at that time? So, or like, do you have to wait until they get into like normal position?
If they're, I saw a chat. When they're proned and they're intubated, typically it's not speech doing the oral care, it's going to be nursing staff. And it is going to be very limited what oral care can be performed because they already have a tube in their mouth, and so it just gets it gets tricky. I think the emphasis on oral care is after they get extubated, we get consulted, and now we're thinking about swallowing.
Yeah, so the next question is, what are the volumes of trial you'll evaluate before making a diet recommendation?
It just depends. Typically for me, if I'm, let's say the patient, also I want to make a caveat, you don't want to try a ton of volume for patients who you think are most likely aspirating and they're still in a tenuous medical state. So I say try volume when you think they're medically stable, they really could probably get on a diet and you want to push a little bit more. So for patients like that, usually I'll try like a whole cup of water, that's 8 ounces in the States. So how many mLs is that? 8
About,
times 30.
about 240. So I agree with you, Ruth. I think if I'm gonna say someone could be in a diet and doesn't need the NG tube, I always, my rule of thumb is I want them to be able to eat a whole bowl of, if they're doing jalo or like a rice porridge, I want them to eat the whole bowl of it, and then I want them to drink a whole cup of something before I will say yes, they're safe for PO. I'm never going to say someone's safe for oral intake from 2 sips of water. That's not enough for me to see. And I know we were talking about the 90 ml swallow test before the 3 ounce water challenge in one of our prior lectures that we talked about. And so at least you want to get that 90 ml minimum, I'd say. And if you can get more than that, that's only going to benefit before you start a diet. But great point, Ruth, that's, you want to let it be kind of the last, when you think they're actually medically ready to eat and drink. That was a really good point.
Yeah. And the thing to remember too is that the case study I'm sharing, this is kind of like one of the more severe cases. There are plenty of COVID patients that don't go through 2-week intubations or 3-week intubations. And so every patient does look different. So the rate at which we progressed this patient was pretty slow. We gave him a lot of time in between days when we reevaluated, and we were very conservative. You don't necessarily have to do that for every patient. Again, it just depends on what the risk factors are.
Yeah, so just a general question, there's one in both Nepal and US settings, is diet modification considered to be the last resort for dysphagia management?
I'd say definitely, and especially in Nepal. Someone earlier pointed out that it's really difficult here to get commercial thickeners, and natural thickeners don't maintain the thickness and the really standard consistencies. I would say, 90% of what I do is compensatory strategies, strengthening and holding PO, keeping the NG tube longer until someone can tolerate thin liquids. So especially, like, my practice has shifted in the States. I was much quicker to try honey thickened liquid, nectar thickened liquid, because those were readily available. And here especially, I'm going to do everything compensatory strategy wise. I may start some bites of puree or things much earlier than I would try to do a thickened liquid, because I just have not had great success here with naturally thickened liquids. For trials, for little sips and things, yes, but as a diet prescription, I've not had great success. So I agree totally that diet modifications are our last step. That was a great question as well.
So thank you for answering that. So the next question is, if we have a drowsy patient, how are we going to assess the progress in swallowing? Or in the cases like Ruth was talking about, so in different ages after post intubation as well, the GCS score was still not normal, and then they still had a little bit of confusion, delusion. So how do we go ahead with that? So I think the question is in general that way.
Honestly, sometimes it just does take time, and there are factors that are out of our control. We can't control what medications the patient is getting. We can't control the disease in general, but some things to look at are, can we reorient the patient? Can we do those delirium management kind of tips that could be helpful? And also sometimes the patient just needs stimulation. So you walk into the room and the patient is completely lethargic and attended, but you flip on the lights and you raise their head of bed and you do your sternal rub. If they don't have cardiac surgery, and you put a wet washcloth on their face. And sometimes that really does wake them up more, and it's then they're kind of ready to go. So it really just depends on the patient.
Okay. Yeah, I think those are the questions that we have so far. And I just wanted to ask Sarah, do you want to start the questions now or like after the case, and then we can keep like 10 minutes break and then come back and do the discussion on the assessment
You
part?
know, it's 8:30 here, and we've been at it for about 2 hours.
Uh-huh.
I'm wondering if we should go ahead and do the assessment.
Uh-huh.
I don't know how everyone else is feeling.
Okay. So we'll
What's everyone else thinking? Maybe if people wanted to do, if you want to hear another case study, maybe type. I think it's up to you guys if you wanted another case study or if you're ready to get on with your evening and go do other things since it is Saturday evening.
We'll finish the case study, I guess, because that's one thing where we are trying to get hold of and transfer the knowledge. So I think we'll do that, and then depending upon the time, we'll do the rest of the things. Is that okay?
Okay. So Ruth, one more case study. What do you think?
One more case study. I'm ready. I can do it.
Yeah. Great.
I know that you, as an aside, I know that you had wanted to talk about swallowing exercises. I have the slides in there. I have some videos. Maybe we can just skip those.
I think so. Yeah, I think people are pretty familiar with those. And if you wanted to email your presentation to me, if you feel comfortable with that, and we can share it with the SHAN group as well.
Yeah, okay. I can totally do that. All right, hang in there, guys. We're almost at the end. And again, if anyone has any questions, you can chime in while I'm talking, even if that can help clarify something. So let me share my screen again. All right. Let's go on to our second case study. This is a 58-year-old male. He has a history of obesity. He's admitted with difficulty breathing. Diagnoses include COVID-19. He did receive convalescent plasma therapy, which we're trialing in the States. Basically, they just take plasma from people who have recovered from coronavirus and they have the COVID antibodies, and they give it to the patients who are in the acute illness stage. He also developed a pneumonia, which I think we're seeing is getting more common because of just general pulmonary weakness, more prone to getting pneumonia. He gets septic shock. He has acute kidney injury, so he requires CRRT. This is basically just continuous dialysis. So the patients are so weak that they can't sustain dialysis every other day and having that much blood taken off and then put back in. So he's on a continuous dialysis that runs for hours at a time every single day. And this man was intubated for 20 days, so almost 3 weeks, just about. When the SLP first got consulted, he was on 95% FiO2 via high-flow nasal cannula. So just to recap, high-flow nasal cannula is almost like CPAP. It's instead of a mask that covers your face, it's just a nasal cannula that kind of goes under your nose. But he's at 95%. Obviously, we're not going to try NPO, so we hold off. And then we come back another day. This is 5 days after extubation. He's now on 50% FiO2 via the high-flow nasal cannula. He is still in the ICU. He does not have an NG tube. His GCS is 12. He's very confused. His oral MEC looks normal, but his laryngeal exam does not. So he is severely dysphonic. Breathy, he's unable to cough to command because he's so weak / confused. He cannot do the SD ratio because he is so confused. But we walk in the room and we realize he sounds really, really gurgly. His voice sounds really gurgly even before we've given any PO. So when I hear a patient talking and it sounds like they're talking underwater, it's bubbly, it's hydrophonic, I'm concerned about poor secretion management, because what I'm thinking is, okay, are you not even swallowing your saliva correctly? So it's slipping into the laryngeal vestibule, possibly contacting your vocal cords and creating that wet vocal quality. A study by Murray has shown that patients who aren't managing secretions are at super high risk of aspirating. There's a definite correlation between the two. So immediately for me, listening to this patient's voice, it's a red flag that he probably has pretty significant dysphagia. So the speech therapist tries some consistencies the patient doesn't show any pharyngeal symptoms of aspiration, but because of his altered mental status, he is intermittently refusing and really just taking minimal PO. So because of all his risk factors, we limit what we try. At this point, he's got prolonged intubation, his vocal quality is impaired, he has high O2 needs, remember he's at 50%, and he's also confused. So we're recommending NPO, and we talk to the nurse and the doctors, he needs a tube feed because he's at such high risk of silent aspiration. We come back the next day. At this point, he's at 40%. So they've weaned down a little bit, not too much, but a little bit. Still in the ICU. Thankfully, he has an NG tube now. His GCS has gone up a little bit. He's still disoriented, but better than the day before. But he's still severely dysphonic. And again, we try thin and nectar thick liquids. He doesn't show any pharyngeal symptoms, but because of all his risk factors, we still recommend NPO. And you may think, why? He's on 40%. So I mean, that's a a level of oxygenation where the patient could potentially be safe for swallowing. He wasn't showing any signs of aspiration, but why still NPO? And it really just goes back to, remember, he's only been extubated for 6 days, and he was intubated for 3 weeks before that. So his voice still sounds horrible. And with those risk factors, even if he's not showing signs, we're really not going to initiate a diet. Also, we try to do exercises, and he deconditions fast. He can barely get through 10 effortful swallows. He's needing max Qs. He's showing rapid fatigue. All this are red flags that should be popping up for, okay, this patient isn't ready to eat yet. 2 days later, he's now on 3 liters via the nasal cannula. So this is good. We're weaning down from oxygen. He now has transferred to an ICU step-down unit, which isn't quite the general floor yet, but at least isn't in the most intensive ICU. He still presents with dysphonia, but he actually looks okay with nectar-thick liquids via teaspoon. So we recommend that. And I want to draw your attention to the small quantities that we're recommending he take PO. So he's still too risky. We don't want him to chug a whole cup of the nectar. So we're really putting in some strategies in place. And this is kind of what Sarah was talking about. What strategies can we implement that can make the patient a little bit safer, especially if diet modification isn't an option. A day afterwards, he's on the general floor now. They pulled the NG tube, which nobody likes to keep the NG tube in the hospital. So they pulled it. He's like, oh, he's on nectar thick liquids via teaspoon. So, all right, let's see how he does with his swallowing. His GCS has improved. He's still dysphonic, not quite as bad as usual. So he does show signs of aspiration with thin liquids and the mixed consistency, which what we try is a fruit cup. So you have fruit and juice, and it's both a liquid and a solid. He looks okay with puree though. So let's try a puree diet with the nectar thick liquids. And any medications he has, we want the nurses to crush them. We don't want him to swallow those meds whole. So we give it a few days. A week later, we come back. He still looks like he's tolerating this diet, the puree nectar. He isn't going into respiratory distress. He is still at 3 liters nasal cannula. He's not running a temperature. So, okay, yes, we're high risk for aspiration, but we seem to be doing okay on the diet. So we try a mechanical soft, no symptoms. We initiate a mechanical soft diet with nectar thick liquids, still recommending medications crushed. And we try some dysphagia exercises, which at this point, he's able to carry over on his own. Before, he wasn't because he was so confused. Now, 3 weeks after he is extubated, he's finally COVID negative. So we decided to do a video fluoroscopic swallow study. I do want to draw your attention to some of the impairments that we still see even 3 weeks after extubation. From the oral phase, he has delayed tongue initiation. And from a pharyngeal perspective, he does have decreased hyolaryngeal elevation and excursion. He does have decreased laryngeal vestibule closure and incomplete base of tongue retraction. So we still have some residual dysphagia 3 weeks post extubation. But the good news is he only had trace penetration with thin liquids during the swallow. They didn't reach the level of the vocal cords, he didn't aspirate, and we tried a little bit more volume on the video, as much as volume as we can when the patient is getting x-rayed, and he looked great with a puree and regular. So the recommendation was made for regular diet, thin liquids. We signed off. In summary, just to kind of reiterate what we've been talking about, the longer the intubation, the higher the risk for silent aspiration, and also that risk for aspiration increases as the O2 requirements increase. So sometimes if your patient is on that much oxygen and they're confused, they really wouldn't benefit from dysphagia exercises, it's better to just hold off. And again, you're gonna have to stand your ground. Doctors always want patients to eat, but sometimes it's just not the right time. And keep in mind too, if a patient sounds really wet and gurgly as you walk into the room, is a concern that they're not swallowing even their saliva safely, which does correlate with dysphagia and aspiration when we start trying solids and liquids. Consider compensatory strategies to decrease aspiration. Instead of using a straw and taking multiple sips in a row, can you take one single sip? Can you use a teaspoon? Is there something you can do to help the swallow? And then also, similar to the previous patient, this patient had rapid fatigue. So we know that there is lung damage from COVID, especially for when it progresses to the point where the patients need intubation or even tracheostomy. So there's a rapid fatigue that we're seeing in these patients and rapid deconditioning that will impact breathing and swallow coordination. So something that I've found helpful was to ask PT and OT how the patients are doing with them. Sometimes when the patient is lying in the bed, they look okay, they're not short of breath. But if the PT says, oh yeah, they were satting at 98%, but literally I went to stand them and all of a sudden their sats dropped to 80%, that's a concern. And that tells you as a speech therapist, okay, even though in bed they look okay, maybe they're even talking with you, but their overall deconditioning is still a very big risk factor for their dysphagia. And that is the end of this case study. And I'll take any questions if you all have any, and Sarah too.
Thanks.
That's great, Ruth.
Sarah is going to talk about something now.
Yeah, I can show, someone asked about what to do if a patient can't follow the instructions for an effortful swallow. My rule is any kind of swallow for practice, if your NPO, is better than no swallow at all. So if a patient can't get to the level of effortful swallow or tongue press, pull your lips back, swallow hard, and can't follow the multiple directions, I'm going to just say swallow, swallow, swallow. Because I would rather you swallow 10 times with me and I can document you swallowed 10 times in 5 minutes than me trying to work so hard to get the effortful swallow that we miss that practice time. So I don't know if that answers your question some, but if they can't follow the instructions to do an effortful swallow, usually what I'll say is put your tongue up and swallow as hard as you can. If they can't do that, oftentimes I'll use a empty spoon. And how you were saying, should we use carbonation or ice chips or sour stimulus? A lot of times I'll just do the spoon and I'll do a tongue press with a bit of tongue-based massage here. And sometimes that's enough to elicit a swallow. It may not be the textbook beautiful, effortful swallow, but oftentimes that's a good starting point for our patients who've not swallowed well. I hope that helps you just a little bit, Prabha. I think that was your question. And Ruth, for me, Masako, Shakir's, and effortful swallows are kind of the triangle of exercises that after a bedside, I can start those with anyone without my adjunctive swallow test to see exact area of dysfunction, because those are gonna only help any patient, or kind of what my rule is. I don't know if you
Yeah, I would agree with that. I know that it's hard to know exactly what sort of laryngeal dysfunction we're working with since we can't do objectives, but I think you can infer that the hyolaryngeal complex is compromised and those and maybe pharyngeal wall weakness, and so those exercises do target that. And then something to remember about the Shakir is that if they have a trach, it gets a little bit trickier because you just have to be cautious with the trach. And of course, if they have, you know, any sort of sternal precautions too, you don't want them to be lifting up and down, especially if they've had some sort of cardiac surgery. It's nice to hear that you all have the masks that have the clear screen, because we don't. And so it's very difficult to model any exercises because we're literally just in our PPE.
That's a great point. Vivek, if you can make it so I can share screen, I actually found the picture of Deepika in the mask so I can show everybody. And then the points about the ice chip protocol and the evidence that patients can improve with sour things, those things are very true. I'm not saying don't do those things. Before I do ice chips and before I would do anything else orally with a patient with a high risk of aspiration, they need very good oral care. That's the Fraser free water protocol. If you haven't done good oral care before you're giving patients bits of ice and they're at a high aspiration risk, the ice that they aspirate will take that bacteria from their mouth and can go to their lungs. So I'm not at all saying don't do sour or ice chips, but I'm saying before you do those things, oral care is the key.
Sarah,
but okay, let me share my little, this is our Deepika. So here's Deepika, and these are just masks. We found the pattern on, where did we find the pattern? We found it on YouTube, and we were able to make it here. So we've been wearing these masks so that we can work with our patients quite a bit easier, just so that they can see us. And then just, this is the patient who was not a COVID positive patient, but since we're still doing aerosol generating procedures, I just so you guys know, this is the gear we're wearing at Green Pastures when we're doing anything that could be an aerosol generating procedure. We're doing reusable gowns, gloves, normal surgical mask, head covering, and face shield, so that everything except for the gloves and the mask are reusable, just because that's what we're able to use right now. Last thing I wanted to show you guys, I know we're almost out of town. We're going to email this to you. This was developed from Deepika did a ton of work on this, to have communication boards that can be printed out in Nepali that has common COVID symptoms, and you know, that you guys can print these things so that patients who are intubated have a way to communicate. So SHAN also approved this, and this will be emailed to you all as a way to use in your COVID settings. Sorry, I kind of took all the last little bit of time.
You're good.
Yeah, that's all. I think we'll just come back for a few minutes. So we have some discussion I think we'll still like to have. So will it be possible for everyone to come back again for another 5 minutes? And I promise I'll leave everybody after that, because I know it's Saturday. Thank you for taking time. Please join us with the same link, and we'll have a little bit more discussion, and then we'll call it a day for today. Thank you very much.